The Trauma Center is an organization responsible for the trauma care in our region. There's one level 1 trauma center. This is the Erasmus Medical Center. We will see each year about 450-500 polytrauma patients. In the Netherlands, we have 4 helicopter medical teams, 1 in Rotterdam. As a level 1 trauma center, we have all physicians staffed on the helicopter medical team, and they are very experienced in trauma care and non-trauma care, but for critical ill patients.
I started with a project of providing pre-hospital thoracotomies, which is quite unique for the Netherlands. We now are researching if REBOA, resuscitative endovascular balloon occlusion of the aorta, is another option. The average rates of survival for emergent thoracotomies are similar to South Africa and the USA, and that's mainly due to the collaboration we have with our Ministry of Defense.
The Erasmus Medisch has a close and very active collaboration with the Ministry of Defense, with the armed forces. We bring our war experience to the hospital and can use that in this very large trauma center. Also, we can keep our skills up to date, obviously. So we work with everybody, and we normally work in white, like everybody else here.
In the Netherlands, the trauma surgeon is head of the trauma team, and he is experienced in fracture care, but also in soft tissue and thoracic and abdominal trauma. We do damage control laparotomy or resuscitative thoracotomy, and also intervention radiology is possible 24/7 a day.
We do a stabilization in the ER department, and subsequently we have OR facilities at the ER, in the OR. We have intensive care units, or in stable patients a ward. The team consists of 8 consultant trauma surgeons, so we are quite a large team, but on top of that we have pillars, certain specific expertises, and we have organized that in teams who take care of specific parts of the body.
In our hospital we see many multi-traumatized patients, so we have a very low threshold to do a CT scan of the thoracic cavity. I'm especially focusing on the presence of rib fractures. Rib fractures are, up to me, underestimated, and we need more data on how to treat these fractures. That's why we set up a multi-center randomized controlled trial for multiple solitary rib fractures, to operate on them, and the other arm we don't operate on them.
We see approximately 80 to 100 patients with a pelvic injury a year that need surgical treatment. And we have a hybrid OR in which we can perform minimally invasive treatment with high-end, high technical resolution and software that provides us the possibility to be very precise in what we do.
We have done some RCTs, a randomized controlled trial on proximal humeral fractures. And for example, for elbow injuries, instability of the elbow, we will treat this with an external fixator, a dynamic one, with immediate mobilization afterwards, because we like to prevent stiffness. And we have very good outcome and satisfaction of these patients.
With regard to lower extremity, especially the lower leg, we have an excellent collaboration with our plastic surgeons, and even in the middle of the night or at the weekend we have the opportunity to do a definitive treatment in a very early phase. We have research projects going on, for example, the effect of certain nailing techniques with regard to complaints on the long term. We also have been involved in the development of specific new implants that are antibiotic coated.
One of the other projects we started about 2 years ago is the osseointegration program. The procedure of osseointegration is when we use titanium implant. The femur is reamed to the diameters of the implant, and the implant is put press fit into the femur, and then by partial loading the bone will grow into the implant, and then the patient is able to move his prosthesis, and there's no need of a socket anymore. Surgery is only a minute part of the procedure. Real work for the patient, the rehab program, it takes about 3 months at least.
We have a collaboration with the Technical University of Delft to see if they walk better, just the quality of walking, and if they can walk longer. We also do training programs within Europe to learn how to do the osseointegration procedure and the screening before the surgery and the rehabilitation program afterwards.
I had an operation 2 years ago and I'm happy with it, what I have now. With the other operation that I have, the symptoms was very painful. With this, you can walk freely. I can on the bike, I can shopping, I walk on the stairs. The quality of life is back to me. The socket is gone and the pain is gone.
We also see many patients who are referred from other hospitals with problems with fracture healing, like infected non-unions or bone segment defects. This is a circular fixator which you can use with an infected non-union, for example. Also in patients who have a post-traumatic limb deformity. And then with the rings and a computer model we can adjust the position of the fracture. There are not many hospitals in the Netherlands doing this, so I'm quite proud to be able to do this.
We are also participating in international education programs. We are running courses together with international colleagues. We are also going to visit other hospitals to stay in the front line of the treatment of trauma patients.